Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition, Chapter 3, Reproductive Anatomy and Physiology. An understanding of the structure and function of the reproductive organs is necessary for the effective nursing care of women during and after their reproductive years and for couples who require family planning or infertility care. This chapter reviews basic prenatal development, sexual maturation, and the structure and function of the female and male reproductive systems. Because of its emphasis in the book, the female reproductive system is discussed most extensively. Sexual development. Sexual development begins at conception, when the genetic sex is determined by the union of an ovum and a sperm. During childhood, the sex organs are inactive and then become active during puberty. Prenatal development. The mother's ovum carries a single X chromosome. Each of the father's spermatozoa carries either an X chromosome or a Y chromosome. If an X-bearing spermatozoon fertilizes the ovum, the offspring's genetic sex is female. If a Y-bearing spermatozoon fertilizes the ovum, a genetic male offspring results. Although genetic sex is determined at conception, the reproductive systems of males and females are similar, or sexually undifferentiated, for the first 6 weeks of prenatal life. During the 7th week, differences between males and females appear in the internal structures. The external genitalia continue to look similar until the 9th week, when these outer structures begin to change. Differentiation of the external sexual organs is complete at approximately 12 weeks of gestational age. During fetal life, both ovaries and testes secrete their primary hormones, which are estrogen and testosterone, respectively. Testosterone causes development of male sex organs and external genitalia, and its absence results in development of female sex characteristics. Although estrogen is secreted by the fetal ovary, the hormone is not required to initiate development of female sex structures. Childhood. The sex glands of girls and boys are inactive during infancy and childhood. At sexual maturity, the hypothalamus stimulates the anterior pituitary gland to produce hormones that in turn stimulate sex hormone production by the gonads, the reproductive sex glands. Sexual maturation. Puberty refers to the time during which the reproductive organs become fully functional. It is not a single event, but a series of changes occurring over several years during late childhood and early adolescence. Primary sex characteristics relate to the maturation of the organs directly responsible for reproduction. Examples of primary sex characteristics are maturation of ova in the ovaries and production of sperm in the testes. Secondary sex characteristics are changes in other systems that differentiate females and males, but do not directly relate to reproduction. Examples of secondary sex characteristics in the female include breast development, selective distribution of fat in breasts, buttocks, and thighs, pubic and axillary hair, and higher-pitched voice. Secondary sex characteristics in the male include increased muscle mass, growth of hair on the face and body, as well as pubic and axillary hair, and development of a deeper voice. Initiation of sexual maturation. Changes of puberty occur in an orderly sequence in the somatic cells, body cells other than the gametes, of both genders. Not all factors involved in the initiation of sexual maturation are known. Secretions of the hypothalamus, anterior pituitary, and gonads all play a role. The hypothalamus can secrete gonadotropin-releasing hormone, GnRH, to initiate puberty during infancy and early childhood, but does not do so in significant amounts until late childhood. Production of even tiny quantities of sex hormones by the young child's ovaries or testes inhibits secretions of the hypothalamus, preventing premature onset of puberty. Maturation of another brain area, as yet unknown, probably triggers the hypothalamus to initiate puberty. The maturing child's hypothalamus gradually increases production of GnRH beginning at age 9 to 12 years. The level of GnRH increases slowly until it reaches a level adequate to stimulate the anterior pituitary to increase its production of follicle-stimulating hormone, FSH, and luteinizing hormone, LH. The ovaries and testes increase production of sex hormones and begin maturing gametes, reproductive cells, an ovum in females and a sperm in males, in response to higher levels of FSH and LH. Sex hormones also induce development of secondary sex characteristics. Table 3.1 lists the major hormones that play a role in reproduction. Puberty varies among individuals. These variances include the age puberty begins and the time required to complete these changes. Hormonal changes of puberty begin approximately 6 months to 1 year earlier in girls than in boys. The growth spurt associated with puberty also begins earlier for girls than for boys. The obvious changes of puberty in girls, such as breast development and height increase, begin an average of 2 years before changes in boys. Changes of puberty occur in an orderly sequence in both genders. Increases in height and weight are dramatic during puberty, but slow after puberty until mature heights and weights are attained. Research has identified a link between early onset of puberty and obesity in girls, as well as a delay in puberty for those with less body fat. Female puberty changes. As girls mature, the anterior pituitary gland secretes increasing amounts of FSH and LH in response to the hypothalamic secretion of GnRH. These two pituitary secretions stimulate secretion of estrogens and progesterone by the ovary, resulting in maturation of the reproductive organs and breasts and development of secondary sex characteristics. The first notable change of puberty in girls, development of the breasts, begins at approximately 8 to 13 years of age. Menstruation occurs about 2 to 2.5 years after breast development, with an average age range of 9 to 16 years. Breast changes. Initially, the nipple enlarges and protrudes. The areola surrounding the nipple also enlarges and becomes somewhat protuberant. These changes are followed by growth of the glandular and ductal tissues. Fat is deposited into the breasts to give them the characteristic rounded female appearance. During puberty, a girl's breasts often develop at different rates, resulting in a lopsided appearance until one breast catches up with the other. Body contours. The pelvis widens and assumes a rounded, basin-like shape that favors passage of the fetus during childbirth. Fat is deposited selectively in the hips, giving them a rounder appearance than those of the male. Body hair. Pubic hair first appears downy and becomes thicker as puberty progresses. Axillary hair appears near the time of menarche. The texture and quantity of pubic hair and axillary hair vary among women and ethnic groups. Women of African descent usually have body hair that is coarser and curlier than that of white women. Asian women often have sparser hair compared with women of other racial groups. Skeletal growth. Girls grow taller for several years during early puberty in response to estrogen stimulation. The growth spurt begins approximately 1 year after breast development begins. Estrogen also causes the epiphyses, growth areas of the bone, to unite with the shafts of the bones, which eventually stops growth in height. Reproductive organs. The girl's external genitalia enlarge as fat is deposited in the mons pubis, labia majora, and labia minora. The vagina, uterus, fallopian tubes, and ovaries grow larger. In addition, the vaginal mucosa changes, becoming more resistant to trauma and infection in preparation for sexual activity. Cyclic changes in the reproductive organs occur during each female reproductive cycle. Menarche. Approximately 2 to 2.5 years after the beginning of breast development, girls experience their menarche, or first menstrual period. Early menstrual periods are often irregular and scant. These early menstrual cycles are not usually fertile because ovulation occurs inconsistently. Fertile reproductive cycles require preparation of the uterine lining precisely timed with ovulation. However, ovulation may occur during any female reproductive cycle, including the first. The sexually active girl can conceive even before her first menstrual period. Delayed onset of menstruation is called primary amenorrhea if the girl's periods have not begun within 2 years after the onset of breast development or by 16 years of age, or if the girl is more than 1 year older than her mother or sisters when their menarche occurred. Secondary amenorrhea describes absence of menstruation for at least 3 cycles after regular cycles have been established or for 6 months. Both primary and secondary amenorrhea are more common in females who are thin. Women who are competitive athletes or dancers, or who suffer from eating disorders, e.g. anorexia nervosa or bulimia, may have too little fat to produce enough sex hormones to stimulate ovulation and menstruation. Pregnancy is also a common cause of secondary amenorrhea. Both primary and secondary amenorrhea may result from inadequate pituitary stimulation of the ovary or failure of the ovary to respond to pituitary stimulation. Amenorrhea may also be caused by excessive androgenic hormones from the adrenal glands, which have a masculinizing effect. Male puberty changes. Secretion of GnRH by the hypothalamus stimulates secretion of LH and FSH from the anterior pituitary. LH and FSH then stimulate secretion of testosterone and eventually cause spermatogenesis, or formation of male gametes, or sperm, in the maturing adolescent. Testosterone stimulates development of a boy's reproductive organs and secondary sex characteristics. The first outward sign of male puberty is growth of the testes, which may begin as early as 9.5 years of age. Penile growth begins approximately 1 year later as the circumference and length of the penis increase. The skin of the scrotum thins and darkens as the sexual organs mature. Final male sexual maturation is complete at approximately 17 years of age. Nocturnal emissions. Often called wet dreams, nocturnal emissions commonly occur during the teenage years. The boy experiences a spontaneous ejaculation of seminal fluid during sleep, often accompanied by dreams with sexual content. Boys should be prepared for this normal occurrence so they do not feel abnormal or ashamed or fear they have an infection or other problem. Body hair. Pubic hair growth begins at the base of the penis. Gradually, the hair coarsens and grows upward and in the midline of the abdomen. Approximately 2 years later, axillary hair appears. Facial hair begins as a fine, downy mustache and progresses to the characteristic beard of the adult male. In most boys, chest hair develops, and some boys have hair on their upper backs. The amount and character of body hair vary among men of different racial groups, with Asian and Native American men often having less than white or African American men. The quantity and character of body hair among men of the same racial group also vary. Body composition. Because of the influence of testosterone, men develop a greater average muscle mass than women. At maturity, a man's muscle mass exceeds the woman's by an average of 50%. Explaining the biologic advantage of men in tasks requiring muscle strength. Skeletal growth. Testosterone causes boys to undergo a rapid growth spurt, especially in height. A boy's linear growth begins approximately 1 year later than a girl's and may continue into his 20s. Testosterone eventually causes union of the epiphysis with the shaft of long bones, as estrogen does in girls. The height-limiting effect of testosterone is not as strong as that of estrogen in females, with the result that boys grow in stature for several years longer than girls. The male's greater average height at maturity is the combined result of beginning the growth spurt at a slightly later age and continuing it for a longer time. A boy's shoulders broaden as his height increases. His pelvis assumes a more upright shape, with narrower diameters and heavier composition than the female pelvis. A man's pelvis is structurally suited for tasks requiring load-bearing. Voice changes. Hypertrophy of the laryngeal mucosa and enlargement of the larynx cause the male's voice to deepen. Before reaching their lower tones at maturity, many boys experience embarrassing cracking or squeaking of their voices when they speak. Decline in fertility. The climacteric is a transitional period that starts as female fertility declines and extends through menopause and the postmenopausal period. In most women, the climacteric occurs between ages 40 and 50 years. Maturation of ova and production of ovarian hormones gradually decline. The external and internal reproductive organs atrophy somewhat as well. Menopause is the term used to describe the final menstrual period. However, menopause, permanent cessation of menstruation, and climacteric are often used interchangeably to describe the entire gradual process of change. Perimenopause is the time from the onset of changes associated with the climacteric, continuing for approximately 2 to 5 years after the last menstrual period. See Chapter 27 for more information about the woman's needs during this phase of her life. Men do not experience a distinct marker event like menopause. Production of testosterone in sperm gradually declines, and sexual function decreases in the late 40s and 50s. Female reproductive anatomy. The nurse needs a basic knowledge of the structure and function of the external and internal reproductive organs to understand their roles in pregnancy and childbirth. Table 3.2. Let's take a look at that. Table 3.2. Functions of female reproductive and accessory organs. Organ, vagina. Function, passageway for menstrual flow. Female organ for coitus. Receives male penis during coitus. Passageway for fetus during birth. Uterus. Houses and nourishes fetus to sufficient maturity to function outside mother's body. Propels fetus to outside. Fallopian tube. Passageway for ovum as it travels from ovary to uterus. Site of fertilization. Ovaries. Secrete estrogens and progesterone. Contain ova within follicles for maturation during woman's reproductive life. Breast alveoli. Secrete milk after childbirth. Acinar cells within alveoli. Lactiferous ducts. Collect milk from alveoli and conduct it to outside. External female reproductive organs. Collectively, the external female reproductive organs are called the vulva. These structures include the mons pubis, labia majora and menorah, clitoris, structures of the vestibule, and perineum. Figure 3.1. Mons pubis. The mons pubis is the rounded, fleshy prominence over the symphysis pubis that forms the anterior border of the external reproductive organs. It is covered with varying amounts of pubic hair. Labia majora and Menorah. The labia majora are two rounded fleshy folds of tissue that extend from the mons pubis to the perineum. They have a slightly deeper pigmentation than surrounding skin and are covered with pubic hair. The labia majora protect the more fragile tissues of the external genitalia. The labia minora run parallel to and within the labia majora. Labia minora extend from the clitoris anteriorly and merge posteriorly to form the fourchette, which is the posterior rim of the vaginal introitus, or vaginal opening. The labia minora do not have pubic hair. They are highly vascular and respond to stimulation by becoming engorged with blood. Clitoris. The clitoris is a small projection at the anterior junction of the two labia minora. This structure is composed of highly sensitive erectile tissue similar to that of the penis. The labia majora merge to form a prepuce over the clitoris. Vestibule. The vestibule refers to structures enclosed by the labia minora. The urinary meatus, vaginal introitus, and ducts of Skene and Bartholin glands lie within the vestibule. Skene, or periurethral glands, provide lubrication for the urethra. Bartholin glands provide lubrication for the vaginal introitus, particularly during sexual arousal. The vaginal introitus is surrounded by erectile tissue. During sexual stimulation, blood flows into the erectile tissue, allowing the introitus to tighten around the penis. This adds a massaging feeling that heightens the male's sexual sensations and encourages ejaculation. The hymen is a thin fold of mucosa partially separating the vagina and the vestibule. The intactness, or lack thereof, of the hymen is not a criterion of virginity. The hymen may be broken by injury, tampon use, intercourse, or childbirth. Perineum. The perineum is the most posterior part of the external female reproductive organs. The perineum extends from the fourchette anteriorly to the anus posteriorly. It is composed of fibrous and muscular tissues that provide support for pelvic structures. Internal female reproductive organs. The internal reproductive structures are the vagina, uterus, fallopian tubes, and ovaries. Figures 3.2 and 3.3. These organs are supported and contained within the bony pelvis. Vagina. The vagina is a tube of muscular and membranous tissue approximately 8 to 10 centimeters long between the bladder anteriorly and the rectum posteriorly. The vagina connects the uterus above with the vestibule below. The vaginal lining has multiple folds, or rugae, and a muscular layer capable of marked distension during childbirth. The vagina is lubricated by secretions of the cervix, the lowermost part of the uterus, and Bartholin glands. The vagina does not end abruptly at the uterine opening, but arches to form a pouch-like structure called the Vaginal Fornix. Each fornix is described by its location: anterior, posterior, and lateral. The vagina has three major functions. 1, it allows discharge of the menstrual flow. 2, it is the female organ of coitus, male-female sexual union. And 3, it allows passage of the fetus from the uterus to outside the mother's body during childbirth. Uterus. The uterus is a hollow, thick-walled, muscular organ shaped like a flat, upside-down pear. The uterus houses and nourishes the fetus until birth and then contracts rhythmically during labor to expel the fetus. Each month, the uterus is prepared for a pregnancy, regardless of whether conception occurs. The uterus measures approximately 7.5 by 5 by 2.5 centimeters and is larger in women who have born children. It is suspended above the bladder and is anterior to the rectum. Its normal position is anteverted, rotated forward over the bladder, and slightly anteflexed, flexed forward. Divisions of the uterus. The uterus has three divisions: the corpus, the isthmus, and the cervix. Corpus. The corpus, or body, is the upper division of the uterus. The uppermost part of the uterine corpus, above the area where the fallopian tubes enter the uterus, is the fundus of the uterus. Isthmus. A narrower transition zone, the isthmus, is located between the corpus of the uterus and the cervix. During late pregnancy, the isthmus elongates and is known as the lower uterine segment. Cervix. The cervix is the tubular neck of the lower uterus and is approximately 2 to 3 centimeters in length. During labor, the cervix effaces, thins, and dilates, opens, to allow passage of the fetus. The os is the opening in the cervix between the uterus and vagina. The upper cervix and lower cervix are marked by the internal os and external os, respectively. The external os of a childless woman is round and smooth. After vaginal birth, the external os has an irregular, slit-like shape and may have tags of scar tissue. Layers of the uterus. The uterus has three layers: the perimetrium, the myometrium, and the endometrium. Perimetrium. The perimetrium is the outer peritoneal layer of serous membrane that covers most of the uterus. Laterally, the perimetrium is continuous with the broad ligaments on both sides of the uterus. Myometrium. The myometrium is the middle layer of thick muscle. Most muscle fibers are concentrated in the upper uterus, and their number diminishes progressively toward the cervix. The myometrium contains three types of smooth muscle fiber, each suited to specific functions in childbearing. Figure 3.4. 1. Longitudinal fibers are found mostly in the fundus and are designed to expel the fetus efficiently towards the pelvic outlet during birth. 2. Interlacing figure 8 fibers constitute the middle layer. These fibers contract after birth to compress blood vessels that pass between them to limit blood loss. 3. Circular fibers form constrictions where the fallopian tubes enter the uterus and surround the internal cervical os. Circular fibers prevent reflux of menstrual blood and tissue into the fallopian tubes, promote normal implantation of the fertilized ovum by controlling its entry into the uterus, and retain the fetus until the appropriate time of birth. Endometrium. The endometrium is the inner layer of the uterus. It responds to the cyclic variations of estrogen and progesterone during the female reproductive cycle. See figure 3.7. The endometrium has two layers. 1. The basal layer is the area nearest the myometrium that regenerates the functional layer of the endometrium after each menstrual period and after childbirth. 2. The functional layer lies above the basal layer. Endometrial arteries, veins, and glands extend into the functional layer and are shed during each menstrual period and after childbirth in the lochia, vaginal drainage after childbirth. Fallopian tubes. The fallopian tubes, also called oviducts, are 8 to 14 centimeters long and quite narrow, 2 to 3 millimeters at their narrowest and 5 to 8 millimeters at their widest. They form a pathway for the ovum between the ovary and uterus. Fertilization occurs in the fallopian tubes. Each fallopian tube enters the upper uterus at the cornu or horn of the uterus. The fallopian tubes are lined with folded epithelium containing hair-like processes called cilia that beat rhythmically toward the uterine cavity to propel the ovum through the tube. The rough folded surface of its lining and small diameter make the fallopian tube vulnerable to blockage from infection or scar tissue. Tubal blockage may result in sterility or atubal ectopic pregnancy because the fertilized ovum cannot enter the uterus for proper implantation. The fallopian tubes have 4 divisions. 1. The interstitial portion runs into the uterine cavity and lies within the uterine wall. 2. The isthmus is the narrow part adjacent to the uterus. 3. The ampulla is the wider area of the tube lateral to the isthmus where fertilization occurs. 4. The infundibulum is the wide funnel-shaped terminal end of the tube. Fimbriae are finger-like processes that surround the infundibulum. The fallopian tubes are not directly connected to the ovary. The ovum is expelled into the abdominal cavity near the fimbriae at ovulation. Wave-like motions of the fimbriae draw the ovum into the tube. However, the tubal isthmus remains contracted until 3 days after conception to allow the fertilized ovum to develop within the tube. The initial growth of the fertilized ovum within the fallopian tube promotes its normal implantation into the upper uterus. Ovaries. The ovaries are the female gonads or sex glands. There are 2 functions of the ovary. 1. Sex hormone production, and 2. Maturation of an ovum during each reproductive cycle. The ovaries secrete estrogen and progesterone in varying amounts during a woman's reproductive cycle to prepare the uterine lining for pregnancy. Ovarian hormone secretion gradually declines to very low levels during the climacteric. At birth, the ovary contains all the ova it will ever have. Approximately 2 million immature ova are present at birth. Many of these degenerate during childhood, and at puberty, approximately 200,000 to 400,000 viable ova remain. Many ova begin the maturation process during each reproductive cycle, but most never reach maturity. During a woman's reproductive life, only about 400 of the ova ever mature enough to be released and fertilized. By the time a woman reaches the climacteric, almost all her ova have been released during ovulation or have regressed. The few remaining ova are unresponsive to stimulating hormones and do not mature. Support structures. The bony pelvis supports and protects the lower abdominal and internal reproductive organs. Muscles and ligaments provide added support for the internal organs of the pelvis against the downward force of gravity and increases in intra-abdominal pressure. Pelvis. The bony pelvis is a basin-shaped structure at the lower end of the spine, figure 3.5. Its posterior wall is formed by the sacrum. The side and anterior pelvic walls are composed of 3 fused bones, the ilium, ischium, and pubis. The linea terminalis, also called the pelvic brim or iliopectineal line, is an imaginary line dividing the upper or false pelvis from the lower or true pelvis. The false pelvis provides support for the internal organs and the upper part of the body. The true pelvis is most important during childbirth. See Chapter 12. Muscles. Paired muscles enclose the lower pelvis and provide support for internal reproductive, urinary, and bowel structures, figure 3.6. In addition, a fibromuscular sheet, the pelvic fascia, provides support for the pelvic organs. Vaginal and urethral openings are located in the pelvic fascia. The levator ani is a collection of 3 pairs of muscles. The pubococcygeus, which is also called the pubovaginal muscle in the female, the puborectal, and the iliococcygeus. These muscles support internal pelvic structures and resist increases in the intra-abdominal pressure. The ischiocavernosus muscle extends from the clitoris to the ischial tuberosities on each side of the lower bony pelvis. The 2 transverse perineal muscles extend from fibrous tissue of the perineum to the 2 ischial tuberosities, stabilizing the center of the perineum. Ligaments. 7 pairs of ligaments maintain the internal reproductive organs and their nerve and blood supplies in their proper positions within the pelvis. See figure 3.2. Lateral support. Paired ligaments stabilize the uterus and ovaries laterally and keep them in the midline of the pelvis. The broad ligament is a sheet of tissue extending from each side of the uterus to the lateral pelvic wall. The round ligament and fallopian tube mark the upper border of the broad ligament, and the lower edge is bounded by the uterine blood vessels. Within the two broad ligaments are the ovarian ligaments, blood vessels, and lymphatics. The right and left cardinal ligaments provide support to the lower uterus and vagina. They extend from the lateral walls of the cervix and vagina to the side walls of the pelvis. The two ovarian ligaments connect the ovaries to the lateral uterine walls. The infundibulopelvic suspensory ligaments connect the lateral ovary and distal fallopian tubes to the pelvic side walls. The infundibulopelvic ligament also carries the blood vessel and nerve supply for the ovary. Anterior support. Two pairs of ligaments provide anterior support for the internal reproductive organs. The round ligaments connect the upper uterus to the connective tissue of the labia majora. These ligaments maintain the uterus in its normal anteflexed position and help direct the fetal presenting part against the cervix during labor. The pubocervical ligaments support the cervix anteriorly. They connect the cervix and anterior surface of the symphysis pubis. Posterior support. The uterosacral ligaments provide posterior support, extending from the lower posterior uterus to the sacrum. These ligaments also contain the sympathetic and parasympathetic nerves of the autonomic nervous system. Blood supply. The uterine blood supply is carried by the uterine arteries, which are branches of the internal iliac artery. These vessels enter the uterus at the lower border of the broad ligament near the isthmus of the uterus. The vessels branch downward to supply the cervix and vagina and upward to supply the uterus. The upper branch also supplies the ovaries and fallopian tubes. The vessels are coiled to allow for elongation as the uterus enlarges and rises from the pelvis during pregnancy. Blood drains into the uterine veins and from there into the internal iliac veins. Additional ovarian and tubal blood supply is carried by the ovarian artery, which arises from the abdominal aorta. The ovarian blood supply drains into the two ovarian veins. The left ovarian vein drains into the left renal vein, and the right ovarian vein drains directly into the inferior vena cava. Nerve supply. Most functions of the reproductive system are under involuntary or unconscious control. Nerves of the autonomic nervous system from the uterovaginal plexus and inferior hypogastric plexus control automatic functions of the reproductive system. Sensory and motor nerves that innervate the reproductive organs enter the spinal cord at the T12 through L2 levels. These nerves are important for pain management during childbearing. See Chapter 13. Female reproductive cycle. The term female reproductive cycle refers to the regular and recurrent changes in the anterior pituitary secretions, ovaries, and uterine endometrium designed to prepare the body for pregnancy. Figure 3.7. Associated changes in the cervical mucus promote fertilization during each cycle. The female reproductive cycle is often called the menstrual cycle because menstruation provides a marker for each cycle's beginning and end if pregnancy does not occur. The female reproductive cycle is driven by a feedback loop between the anterior pituitary and ovaries. A feedback loop is a change in the level of one secretion in response to a change in the level of another secretion. The feedback loop may be positive, in which rising levels of one secretion cause another to rise, or negative, in which rising levels of one secretion cause another to fall. The duration of the cycle is approximately 28 days, although it may range from 20 to 45 days. Significant deviations from the 28-day cycle are associated with reduced fertility. The first day of the menstrual cycle is counted as day 1 of the woman's cycle. The female reproductive cycle is further divided into two cycles reflecting changes in the ovaries and uterine endometrium. Ovarian cycle. In response to GnRH from the woman's hypothalamus, the anterior pituitary secretes FSH and LH. These secretions stimulate the ovaries to mature and release an ovum and secrete additional hormones to prepare the endometrium for implantation of a fertilized ovum. The ovarian cycle consists of three phases: follicular, ovulatory, and luteal. Follicular phase. The follicular phase is the period during which an ovum matures. It begins with the first day of menstruation and ends approximately 14 days later in a 28-day cycle. The length of this phase varies more among different women than do the lengths of the other two phases. The fall in estrogen and progesterone secretion by the ovary just before menstruation stimulates secretion of FSH and LH by the anterior pituitary. As the FSH and LH levels rise slightly, 6 to 12 Graafian follicles, sacs within the ovary, each containing an immature ovum, begin to grow. Each follicle secretes fluid containing high levels of estrogen, which accelerates maturation by making the follicle more sensitive to the effects of FSH. Eventually, one follicle outgrows the other to reach maturity. The mature follicle secretes large amounts of estrogen, which depresses FSH secretion. The dip in FSH secretion just before ovulation blocks further maturation of the less developed follicles. Occasionally, more than one follicle matures and releases its ovum, which can lead to a multifetal pregnancy. Women who take fertility drugs may release multiple mature ova that are used for assisted reproductive techniques. Chapter 26. Ovulatory phase. Near the middle of a 28-day reproductive cycle, and about 2 days before ovulation, LH secretion rises markedly. Secretion of FSH also rises, but to a lesser extent than that of LH. These surges in LH and FSH levels cause a slight fall in follicular estrogen production and a rise in progesterone secretion, which stimulates final maturation of a single follicle and release of its ovum. Ovulation marks the beginning of the luteal phase of the female reproductive cycle and occurs 14 days before the next menstrual period. The mature follicle is a mass of cells with a fluid-filled chamber. A smaller mass of cells houses the ovum within this chamber. At ovulation, a blister-like projection called a stigma forms on the wall of the follicle. The follicle ruptures, and the ovum with its surrounding cells is released from the surface of the ovary, where it is picked up by the fimbriated end of the fallopian tube for transport to the uterus. Ludial phase. After ovulation and under the influence of LH, the remaining cells of the old follicle persist for approximately 12 days as a corpus luteum. The corpus luteum secretes estrogen and large amounts of progesterone to prepare the endometrium for a fertilized ovum. During this phase, levels of FSH and LH decrease in response to higher levels of estrogen and progesterone. If the ovum is fertilized, it secretes a hormone, chorionic gonadotropin, that causes persistence of the corpus luteum to maintain an early pregnancy. If the ovum is not fertilized, FSH and LH fall to low levels and the corpus luteum regresses. Decline of estrogen and progesterone levels, along with corpus luteum regression, results in menstruation as the uterine lining breaks down. The loss of estrogen and progesterone from the corpus luteum at the end of one cycle stimulates the anterior pituitary to again secrete more FSH and LH, initiating a new female reproductive cycle. The old corpus luteum is replaced by fibrous tissue called the corpus albicans. Endometrial cycle. The uterine endometrium responds to ovarian hormone stimulation with cyclic changes. 4 phases mark the changes in the endometrium: proliferative, secretory, ischemic, and menstrual. Proliferative phase. The proliferative phase occurs as the ovum matures and is released during the first half of the ovarian cycle. After completion of a menstrual period, the endometrium is very thin. The basal layer of endometrial cells remains after menstruation. These cells multiply to form new endometrial epithelium and endometrial glands under the stimulation of estrogen secreted by the maturing ovarian follicles. Endometrial spiral arteries and endometrial veins elongate to accompany thickening of the functional endometrial layer and nourish the proliferating cells. As ovulation approaches, the endometrial glands secrete thin, stringy mucus that aids entry of sperm into the uterus. Secretory phase. The secretory phase occurs during the last half of the ovarian cycle as the uterus is prepared to receive a fertilized ovum. The endometrium continues to thicken under the influence of estrogen and progesterone from the corpus luteum, reaching its maximum thickness of 5 to 6 millimeters. The blood vessels and endometrial glands become twisted and dilated. Progesterone from the corpus luteum causes the thick endometrium to secrete substances to nourish a fertilized ovum. Large quantities of glycogen, proteins, lipids, and minerals are stored within the endometrium, awaiting arrival of the ovum. Ischemic and menstrual phases. If fertilization does not occur, the corpus luteum regresses, and its production of estrogen and progesterone falls. About 2 days before the onset of menstruation, vasospasm of the endometrial blood vessels causes the endometrium to become ischemic and necrotic. The necrotic areas of endometrium separate from the basal layers, resulting in the menstrual flow. The durations of the menstrual phase from the first day of the flow to the last is approximately 5 days. During a menstrual period, women lose approximately 4 milliliters of blood. Because of the recurrent loss of blood, many women are mildly anemic during their reproductive years, especially if their diets are low in iron. Changes in cervical mucus. During most of the female reproductive cycle, the mucus of the cervix is scant, thick, and sticky. Just before ovulation, cervical mucus becomes thin, clear, and elastic to promote passage of sperm into the uterus and fallopian tube, where they can fertilize the ovum. Spinbarkiet refers to the elasticity of cervical mucus. A woman may assess the elasticity of her cervical mucus to either avoid or promote conception, Chapter 25. So having never heard that word before, I had to look it up, the etymology. It's a German word, Spinbarkiet, which describes the tendency of something to be stringy enough to be spun, like into a yarn, I guess. So there you go. The female breast. Structure. The breasts or mammary glands are not directly functional in reproduction, but they secrete milk after childbirth to nourish the infant. The small raised nipple is located at the center of each breast, figure 3.8. The nipple is composed of sensitive erectile tissue and may respond to sexual stimulation. A larger circular areola surrounds the nipple. Both the nipple and areola are darker than the surrounding skin. Montgomery's tubercles are sebaceous glands in the areola. They are inactive and not obvious except during pregnancy and lactation, when they enlarge and secrete a substance that keeps the nipple soft. Within each breast, lobes of glandular tissue secrete milk. These lobes are arranged in a pattern similar to spokes of a wheel around the hub. Between 15 and 20 of these lobes are arranged around and behind the nipple and areola. Fibrous tissue and fat in the breast support the glandular tissue, blood vessels, lymphatics, and nerves. Alveoli are small sacs containing acinar cells to secrete milk. The acinar cells extract the necessary substances from the mammary blood supply to manufacture milk when the breasts are properly stimulated by the anterior pituitary gland. Myoepithelial cells surround the alveoli to contract and eject the milk into the ductal system when signaled by secretion of the hormone oxytocin from the posterior pituitary gland. The alveoli drain into lactiferous ducts, which connect at the nipple to drain milk from all areas of the breast. Function. The breasts are inactive until puberty, when rising estrogen levels stimulate growth of the glandular tissue. In addition, fat is deposited in the breasts, resulting in the mature female contour. The amount of fat is the major determinant of breast size. The amount of glandular tissue is similar for all mature women. Therefore, breast size is unrelated to the amount of milk a woman can produce during lactation. During pregnancy, high levels of estrogen and progesterone produced by the placenta stimulate growth of the alveoli and ductal system to prepare them for lactation. Prolactin secretion by the anterior pituitary gland stimulates milk production during pregnancy, but this effect is inhibited by estrogen and progesterone produced by the placenta. Inhibition effects of estrogen and progesterone stop when the placenta is expelled after birth, and active milk production occurs in response to the infant's suckling while breastfeeding. Male reproductive anatomy and physiology. External male reproductive organs. The male has two external organs of reproduction, the penis and scrotum. Figure 3.9. Penis. The penis has two functions. As part of the urinary tract, it carries urine from the bladder to the exterior during urination. As a reproductive organ, the penis deposits semen into the female vagina during coitus. The penis is composed mostly of erectile tissue, which is spongy tissue with many small spaces inside. The three areas of erectile tissue are the corpus spongiosum, which surrounds the urethra, and two columns of the corpus cavernosum on each side of the penis. The penis is flaccid most of the time because the small spaces within the erectile tissues are collapsed. During sexual stimulation, arteries within the penis dilate and veins are partly occluded, trapping blood in the spongy tissue. Entrapment of blood within the penis causes erection and enables penetration of the vagina during sexual intercourse. The glans is the distal end of the penis. The urinary meatus is centered in the end of the glans. The loose skin of the prepuce, or foreskin, covers the glans. The prepuce may be removed during circumcision, a surgical procedure usually performed during the newborn period, although it may be performed later. The glans is very sensitive to tactile stimulation, which adds to the male's sensation during coitus. Scrotum. The scrotum is a pouch of thin skin and muscle suspended behind the penis. The skin of the scrotum is somewhat darker than the surrounding skin and is covered with small ridges called rugae. The scrotum is divided internally by a septum. One of the male gonads, testicle, is contained within each pocket of the scrotum. The scrotum's main purpose is to keep the testes cooler than the core body temperature. Formation of normal male sperm requires that the testes not be too warm. A cremaster muscle is attached to each testicle. Contraction of the cremaster muscles draws the testicles closer to the body for warming, and relaxation of these muscles allows the testicles to move away from the body for cooling. Internal male reproductive organs. The functions of the male external and internal reproductive organs are summarized in Table 3.3. Testes. The male gonads, or testes, have two functions. They serve as endocrine glands, and they produce male gametes, or sperm, also called spermatozoa. Androgens, male sex hormones, are the primary endocrine secretions of the testes. Androgens are produced by Leydig cells of the testes. The primary androgen produced by the testes is testosterone. Unlike females, who experience a cyclic pattern of hormone secretion, males secrete testosterone in a relatively even pattern. A feedback loop with the hypothalamus and an anterior pituitary stabilizes testosterone levels. A small amount of testosterone is converted to estrogen in males and is necessary for sperm formation. Spermatogenesis occurs within tiny coiled tubes, the seminiferous tubules of the testes, figure 3.10. Leydig cells are interstitial cells supporting the seminiferous tubules and secrete testosterone, which is necessary to form new cells that will mature into sperm. Sertoli cells within the seminiferous tubules respond to FSH secretion by nourishing and supporting sperm as they mature. Unlike females, who have a lifetime supply of ova in their gonads at birth, males do not begin producing sperm until puberty. Normal males produce new sperm throughout life, although production declines with age. At ejaculation, approximately 35 to 200 million sperm are deposited in the vagina. This large number is needed for normal fertility, although a single sperm fertilizes the ovum. Only a few sperm ever reach the fallopian tube, where an ovum may be available for fertilization. When the first sperm penetrates the ovum, changes within the ovum prevent other sperm from also fertilizing it. Chapter 5. Accessory ducts and glands. From the seminiferous tubules, sperm pass into the epididymis within the scrotum for storage and final maturation. In the epididymis, sperm develop the ability to be motile, although secretions within the epididymis inhibit actual motility until ejaculation occurs. The epididymis empties into the vas deferens, where larger numbers of sperm are stored. The vas deferens leads upward into the pelvis and then downward through the penis through the internal and external inguinal rings. Within the pelvis, the vas deferens joins the ejaculatory duct before connecting to the urethra. Three glands, the seminal vesicles, the prostate, and the bulbourethral gland, secrete seminal fluids that carry sperm into the vagina during intercourse. The seminal fluid has four functions: 1. Nourishing the sperm, 2. Protecting the sperm from the hostile pH, acidic environment of the vagina, enhancing the motility of the sperm, and 4. Washing the sperm from the urethra to maximize the number deposited in the vagina.